everyone, I hope you all are doing good. Welcome back to my series on Step 2 Ck preparations. Today we're going to do a very high yield topic, which you can see here, Hydatidiform mole, which is also known as molar pregnancy. There's going to be a lot of clinical vignettes and there's going to be a lot of questions on the Step 2 Ck exam regarding this in the OBGYN and gynecology section, so you need to know this. Molar pregnancy, there's two types. There's partial molar pregnancy and there's complete molar pregnancy. So what happens in partial molar pregnancy, we have an egg which is fertilized by two sperms. And what happens in complete molar pregnancy, we have an empty egg which does not contain the maternal genetic material. This is going to be fertilized by two sperms. So coming to how the patient's going to come to you and how they're going to ask you in the question stem is, a patient might be pregnant, she did her beta HCG, she got her pregnancy results, they're confirmed, and then afterwards she comes to you with normal vaginal bleeding. When you check her uterine enlargement and the position at which her uterus is, for example, the patient says that 10 weeks ago I confirmed my pregnancy, so it's my 12th week of gestation. But when you look at her uterus on the abdominal examination, you see that it's at umbilicus, which is for 20 weeks gestation. So you're going to see uterine enlargement, which is more than the gestational age. After that, that's going to be abnormally high beta HCG. What happens here is beta HCG is a lot, so there's going to be a lot of abnormalities because of that alone. For example, the ovarian cysts that we see here are theca lutein cysts, because we know that beta HCG has effect on theca cells. So why these theca lutein cysts form? These are actually theca cells forming cyst. They're called as theca lutein cysts. So what happens is beta HCG is the culprit behind these ovarian cysts. And then you're gonna see them on ultrasound, obviously, and then you're gonna have hyperemesis gravidarum because of the high beta HCG. Your vomiting center is also activated by this, so you're gonna have hyperemesis gravidarum, and then you're gonna have hyperthyroidism because beta HCG and TSH. Remember, it's TSH, not TRH. Okay, TSH and beta HCG have common structure, so it's gonna cause hyperthyroidism too. And then there's going to be preeclampsia, because this is a very high yield topic, preeclampsia. I'm going to touch on this, but to tell you very lightly, we know that in preeclampsia we have trophoblastic proliferation abnormality, so it does not proliferate properly into the spiral arteries, so we get this preeclampsia. So in this case, there's also trophoblastic abnormality, so this is pretty common that this is going to happen, and we have severe features in it. The patient's going to have severe features in it. Okay, so now we're going to talk about the risk factors. There are two: maternal age, extremes of maternal age, like more than 35 years old or less than 15 years old, and if there was a previous molar pregnancy, it's also a risk factor. So coming to the diagnosis, we have ultrasound. On ultrasound, you're going to see a snowstorm appearance. It's a very telltale sign for this hydatidiform mole. What happens here is you have a black background, and then in the middle you have white spots. So what are those white spots? Actually, those are the hydropeak villi that I talked about in the start. I didn't tell about these in the start. So these are small villi which are formed from the hydropeak villi, which are formed from the trophoblastic tissue of the molar pregnancy. And then you're going to do a qualitative beta HCG. It's going to be very high. And after that, you have histopathologic evaluation of uterine content after you have done DNC. Coming to the management, we have if the patient comes to us with hydatidiform mole, and then you see this on ultrasound, there's snowstorm appearance, and then you get a very high beta HCG. So what you do is you do dilation and curettage, and then after that, the very important point here is, I'm going to highlight it in pink so that you guys remember it. This point is very important because you're going to do serial beta HCG up to 6 months after you do the DNC, because it's very much probable that this person is going to develop gestational trophoblastic neoplasia. This is a very serious condition, so you're going to look for this up to 6 months. When you do DNC, then you're going to have a fall in the beta HCG levels because you have took out the molar pregnancy. But if after some time you see a rise in beta HCG, then you know that there is neoplasia. And also you have to give the patient contraception for 6 months for the same reason, because another pregnancy can actually mask the beta HCG level. You're not going to be able to diagnose it in time. So this was all for today. I hope you liked the lecture, and see you in the next video.